much for your kind invitation. I'm very pleased to participate to your Congress today. So during the next 20 minutes, we will see together how to explore cardiac involvements in patients suffering from systemic diseases with cardiac MRI. This is my disclosures, and none of them are related to this presentation. So as you know, the term systemic disease includes a wide spectrum of pathologies, and a lot of them may lead to heart diseases. So let's try to make it simple. As a radiologist, there are two main clinical presentations in which those patients will be referred to your department for cardiac imaging. First, in an acute context of chest pain mimicking a coronary syndrome, and you will have to look for an inflammation of the myocardium of the pericardium, or in a patient with chronic cardiac symptoms, and then you will explore a cardiomyopathy related to the systemic disease. For both of these scenarios, the modality of choice is cardiac MRI, thanks to its good spatial and temporal resolutions, and also because this is the only imaging modality with an excellent tissue characterization. And this is an example of CMR protocol that we are using in our unit. First, CNIS to explore morphology and function, then the newly developed T1 and T2 mapping, T1 mapping to evaluate fibrosis and infiltration, and T2 to see edema. Then the sequences with gadolinium, first pass perfusion, early gadolinium and late gadolinium enhancements, and then you can repeat T1 mapping to measure the extracellular volume, which is also a parameter of infiltration. As you know, late gadolinium enhancement is historically the main strength of CMR with all these different patterns. The ischemic patterns, subendocardial or transmural in a coronary territory, or non-ischemic, mainly mid-wall and epicardial, and all the different etiologies associated as described on these pictures. And thanks to the different technical progress, CMR is now feasible in most patients, including patients with arrhythmia, shortness of breath, and children. And similarly to CT, we have now 3D sequences to explore the entire cardiac volume, and I hope you can appreciate that this is quite cool, isn't it? So as a radiologist, you have a central role to explore an acute chest pain in a patient with systemic diseases. Of course, if a STEMI is suspected, an angiogram will be performed, and in case of non-significant coronary artery disease, CMR will be the best modality to explore the differential diagnosis to our colleagues, cardiologists, called MINOCA. This is an example of a recent case. We had a 36-year-old man with chest pain and elevated tropos, normal coronary angiogram, and a context of polymyositis. We performed a comprehensive CMR showing elevated T2 and perfusion, so edema, plus patchy early gadolinium enhancement and late gadolinium enhancement with a mid-wall and epicardial distribution corresponding to a typical myocarditis. And if we look at all the etiologies of myocarditis, this is not the only infection, but also most of the systemic diseases we are talking about today, such as lupus or Sjögren's. Myocarditis will be the topic of another presentation, but just to remind you that the diagnosis of myocarditis with CMR is based on the Lake-Lewis criteria. So we need at least 2 of the 3 criteria, namely edema on T2 imaging, increased early gadolinium enhancement, and mural or epicardial late gadolinium enhancement. These criteria have been updated recently, introducing T1 mapping instead, or plus early gadolinium enhancement and late gadolinium enhancement. So if you have a DMA on T2 and a non-ischemic T1 or late gadolinium enhancement abnormality, you can make the diagnosis of myocarditis. This example to remind you that myocarditis might also be seen with CT. This is a young patient with chest pain and elevated tropos and ST elevation on ECG. So we perform a coronary CTA, which was normal. And on delayed CT acquisition, we observed an epicardial enhancement confirmed by CMR. So you can see myocarditis on CT if you realize a delayed acquisition with a low kV protocol 5 minutes after the injection of iodine. And this is probably even easier if you work with a dual energy or a spectral CT scanner, as illustrated on this example from the literature. An important point is that myocarditis in medium and small vasculitis, such as polyarteritis nodosa, Churg, or Wegener, will be a little bit different than a regular myocarditis. We will observe edema, of course, but also perfusion defect and subendocardial patchy late gadolinium enhancement, which is not visible normally. Subendocardial LGE is not in a coronary territory, obviously. This is illustrated by this example of a woman with Wegener granulomatosis admitted for chest pain and elevated tropos. You can see a nodular subtle perfusion defect here in the anterior wall with elevated T2 and patchy nodular late gadolinium enhancement. So this is a vasculitis pattern. Here we are. Another example with similar finding in this man suffering from Churg-Strauss syndrome. On cine imaging, there is a global hypokinesia of the left ventricle, an apical perfusion defect, and a diffuse patchy endocardial late gadolinium enhancement. In an acute context, in addition to myocarditis, lupus and rheumatoid arthritis may lead more frequently than the other systemic diseases to pericarditis, with effusion and enhancement of the pericardium layers at the delayed phase on CT. This may be associated with tamponade, and if the pericarditis becomes chronic, we can observe the typical pattern of constriction on cine imaging with enlarged atria, small ventricles, and paradoxical septum motion. So now let's move to the second clinical scenario of a patient referred to CMR for suspicion of chronic cardiomyopathy in the context of systemic disease. Most of the time, there is a clinical suspicion with ECG abnormalities or an abnormal cardiac echo with features of restrictive or dilated cardiomyopathy. And as you can see on this table, a lot of systemic diseases are leading to restrictive cardiomyopathy. The main example of restrictive cardiomyopathy is amyloidosis, with a very evocative pattern including concentric LV hypertrophy, biatrial dilatation, abnormal inversion time of the myocardium, which get null before blood, and a circumferential subendocardial or diffuse transmural late gadolinium enhancement extended to right ventricle, atrial wall, and valves. Pericardial and pleural effusion are also very common. Amyloidosis is also the cardiomyopathy showing the highest T1 values within the myocardium, with values above 1,100 milliseconds, much more than the other infiltration of the heart. This is an example of an old patient with elderly-related systemic amyloidosis. You can see typical left ventricle hypertrophy on cine, elevated T1, dilatation of the left atrium, and the evocative late gadolinium enhancement pattern. Another typical CMR pattern is the endocardial fibrosis in eosinophilic heart disease, such as SHERG or hypereosinophilic syndrome. Eosinophils have a direct toxicity to endocardium, and on CMR, we normally observe LV hypertrophy and the 3 layers of normal myocardium, circumferential endocardium LGE, and thrombus at the apex. Another example, this young patient with HES and restrictive cardiomyopathy on echo. On cine imaging, we can see the apical LV hypertrophy and endocardial LGE, but here the pattern is incomplete with no thrombus. A last example of eosinophilic heart disease in a chronic context of this patient referred for pericardial effusion in a context of Church-Strauss syndrome, and we find scars of vasculitis with here no edema, so no activity of the vasculitis. Systemic sclerosis may also be associated with restrictive or dilated cardiomyopathy. Similarly to skin or lungs, we can observe fibrosis within the myocardium with edema at an acute stage, and wall thinning has a scar of the fibrosis with elevated T1 and mid-wall subendocardial or transmural late gadolinium enhancement. Last but not least, cardiac sarcoidosis, which most of the time is suspected when lung and mediastinum disease is already known, but look at the mediastinum on CMR2 to depict nodes. CMR is most of the time realized to exclude cardiac localization of the granulomatosis. We must always think about it when we observe subepicardial late gadolinium enhancement in the anterior or the inferior wall with very evocative extension within the septum. And it may be associated with edema at early stage 1 again. Most of the time, there is a good correlation with PET CT, as illustrated here, even if PET has probably a better sensitivity during the active stage of the disease. So to conclude, CMR is the modality of choice to assess cardiac involvement in systemic diseases and should include cine and tissue characterization sequences, and in the former years, T1 and T2 mapping sequences have been an important help to identify myocardial abnormalities. According to the clinical presentation of the underlying disease, CMR is a useful tool to explore inflammatory cardiomyopathy with myocarditis, vasculitis, or pericarditis patterns related to systemic disease or chronic cardiomyopathy, with the different evocative patterns we've just discussed. Thank you very much for your attention, and I'm looking to welcome you in our team as a fellow in lead. Don't hesitate to contact me if you have any question or if you are interested. Thank you very much.
So thank you, Professor Fontana, for nice presentation. So Professor Fontana is online right now. So if any question from the floor audience for Professor Fontana? I have a question for Professor Fontana. No, it's not online right now.
Hello everyone, yes, I'm online.
Yeah. Okay, I have a question for you. So in your presentation, should we do the parametric mapping in all the patients suspect cardiac systemic disease, and how do we find out the normal value of T1 and T2 and ECV in your center? Thank you.
Thank you very much for this very interesting question. You're right. Laboratory at the moment have on your machine T1 and T2 map available. Implement them to your protocol, assess a patient suspecting of cardiac involvement to the systemic disorder. And you're right that it's very important when we read the guidelines, the SCMR guidelines, that the center know the normal value of T1 and T2. And it's recommended have a certain number of normal patients or volunteers tried on your to evaluate the normal values of 1 and T2. We know that T2 is more stable between different machines. Most of the time, normal T2 value is 45 and 5 milliseconds. And regarding T1, there is a wider variability. And for instance, in our center, the normal value of T1 is 950 and 1050. But it's very important to do this calibration.
Thank you, Professor. Any question from the audience for Professor Fontana? Okay, thank you, Professor.
Thank you very much.
Yeah, thank you.